This is Sg2 Perspectives, a conversation with Sg2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
As we think about leveraging our vast data assets, our claims data that we glean from Vizient and other data partners, we can actually use this to develop frameworks that simplify the situation. We started 4 years ago. We created a framework because the AMCs are universally experiencing a capacity crunch, and we created an inpatient portfolio that balances opportunity versus opportunity cost for AMCs. And others have found this incredibly helpful as well from an inpatient planning perspective.
Welcome to Sg2 Perspectives. I'm your host, Trevor DaRin. I have my colleagues with me today, Justin Cassidy and Rachael Zirkelbach. We're going to talk about a new body of research that they've led around our outpatient portfolio. We've already started using it through our executive summit, through a briefing that came out this spring. I want to hear some of the backstory of why we thought it was necessary to undertake work to better understand the outpatient landscape. It's a place so many strategy teams are focusing a majority of their effort. There's not dedicated resources people or common frameworks of how to approach it. This work has been valuable to our members. Justin, why bother? Why did you try to undertake this work? What were you hoping to achieve by tackling and thinking about segmenting outpatient and inpatient portfolios in the ways that you did?
When Sg2 creates strategic frameworks that reduce complexity and lead to action, essentially actionize novel data analyses to understand today and plan for tomorrow. As we think about leveraging our vast data assets, claims data that we glean from Vizient and other data partners, we can actually use this to develop frameworks that simplify the situation. We started 4 years ago. We created a framework. The AMCs are universally experiencing a capacity crunch, and we created an inpatient portfolio that balances opportunity versus opportunity cost for AMCs. Others have found this incredibly helpful from an inpatient planning perspective. As a result of this, AMCs have been buying and building to help contend with that ongoing capacity crunch. Our outpatient framework evolved from that inpatient portfolio work, but instead of opportunity versus opportunity cost, the outpatient portfolio balances expertise with access. There's significant growth forecast across the board. Where should our clients prioritize? What are your ambulatory ambitions? Where do you want to target in this vast space? And lay out a map for that activity.
That couldn't have been a better highlight for our members. You consolidate how we thought about it. Why don't you describe what the product was, the framework, what it looks and feels like?
It's deceptively simple. That's the beauty of it. We segregate Sg2 care families or disease-based groupings into these 5 different categories. They're quantitatively defined. We're leveraging our vast data sets to do this. There were a lot of different failed methods as we were trying to quantitate these categories. The ones that we settled with are terrifically meaningful. Each care family is in a mutually exclusive bin. There are 5 different cohorts. The first is tertiary. That's a high percent of care in an academic health system. We look at all claims within the health system, not just those at the academic medical center. Those that have a higher percentage academic systems is different from inpatient tertiary, which is very procedural focused. There's a lot in this outpatient tertiary bucket that might be surprising to some members. The second cohort is the complex cohort. We settled on looking at a high percent of level 5 highest acuity E&M visits. This is a measure of those patients that are experiencing significant acuity in their condition and are sort of procedural proximal, about ready for surgical referral or other sort of emergent activity in the hospital-based setting. The third cohort is recurring. This includes common chronic conditions. It's a meta statistic, a higher percent of established E&M visits. What's remaining after we carve out the other 2 categories? The fourth is transactional. These are one and done types of encounters, so it's a high percent of urgent or retail care clinic utilization, new patient visits, and level 1 or 2 E&M visits. Finally, preventative care bucket. It's primary care on healthy people, annual physicals, gynecological wellness visits, and screenings and follow-up encounters. We also have a public health domain. We don't have claims in this area, but there's a lot of non-claim-based care, often on vulnerable populations in many communities in the outpatient side. Within those 5 cohorts, tertiary, complex, recurring, transactional, and preventative, different service lines enriched in different cohorts. So cancer, almost all tertiary and complex, general surgery and orthopedics are mostly transactional. Cardiovascular spans all these cohorts. The ambulatory space is vast, and this subsegmentation helps our clients focus their ambitions.
We spent some time thinking through what organizations would need to do well in order to prioritize one side of the framework versus the other. If your focus is on that tertiary or complex care cohort, you'll need to recruit and retain the best specialists in their field. Strong referral channels become important here too. And it's not just focusing on educating folks about your expertise in the field that these specialists provide, also how to refer those patients in, and then how patients will be transferred back to local care. It comes up a lot in oncology. A lot of the oncology falls in the tertiary cohort. When you're thinking about patients who may be able to receive their medical or their radiation oncology in their local hometown, but might need to travel to an AMC or a large network for other aspects of their oncology care, this clear referral channel becomes important so that the patient and the provider know when their care is transferred back to their hometown. If you go to the opposite side of the framework, we've got organizations who hang their hat on the transactional and preventive care. Ample access is paramount here. Patients need to be able to access the care that they want and need however they want it. If they have a cold or an ear infection and they can't get into your organization in a timely manner, they're going to shop around for another provider. That means that investment in digital tools is important, even the most essential, especially if your focus is on this right side of the framework. Virtual care is extremely important for success.
Rachel, you're describing some of how members can use it. Every member I've put this framework in front of just gets it, and it has prompted some great strategic discussions in between points of the different segments. Prompt a discussion. What's our market share in this segment? Is that what we want? How do we divide resources? If transactional is 35% of everything we're doing, are we spending 35% of our resources there? What types of strategic discussions have you prompted with members using, just talking primary care, but I know your conversations are broader than that.
You can get as high level as you want. You can look at a system level view, or you can get as granular as you want, where you look at a service line or an office specific view. We had a member who was looking at nurse practitioner led urgent care and walk-in clinics that were really underutilized. And they wanted to see why they were so underutilized. They would be seeing these low acuity patients, these one and done in and out ear infections, common colds, respiratory viruses. What they actually found was that their primary care base was seeing a lot of those patients instead of pushing them toward the nurse practitioner-led urgent care. Using the framework allowed them to display the data to their primary care providers alongside some education on it's okay for these patients to utilize this clinic. You can still manage their chronic care. You can still be their primary care provider. It also frees up appointment space for primary care providers to manage those chronic care patients who needed intense management while utilizing the resources in the nurse practitioner-led clinic. Justin, you work with our AMCs. How have you seen them use this framework?
I was thinking about that old movie, Jerry Maguire, the famous line, "Show me the money." For strategist clients, they say, "Show me the data" to make the case to their CEOs. This is a key step for strategic execution. They need to see that data in order to act on it and lay out that business case. This framework provides a simple visual roadmap of the vast ambulatory footprint emerging within systems to start to target that strategic activity. I had the privilege of facilitating discussion at a large AMC in the Southeast. The CSO and the CFO were partnered, and that AMC prided itself on caring for the most complex patients, particularly inpatient side. Many AMCs evolved into a large health system over time, many different hospitals, many different community care settings. When we did the market share analysis, while outpatient care did enrich for complex patient market share, they were doing more than their competitors. On the outpatient side, they saw far fewer complex patients than their competition. This was an example of show me the data. They were shocked by this. And the implications were that they were losing inpatient market procedural share. There's significant inpatient growth across the board, but their competitors were getting more of that by cornering that complex market on the outpatient side. It's helped inspire the CMC to enhance ambulatory access. The next step they're undertaking is considering the ancillary revenue potential of associated outpatient services like labs, imaging, DME, and most importantly, specialty pharmacy. This is the show me the money part. This is really where the CFO is starting to get excited about the vast potential of ambulatory opportunity. Collectively, we've seen it prompt smart, pointed investments in expertise and access.
I love the show me the data piece. And the way we have been showing members data for the longest time is by forecasting demand. Did you overlay these two things together to think how our forecast was different across these segments? I know you have because I've seen it.
Of course we have. Sg2's forecast or impact of change for 2024 shows significant growth across the board in the ambulatory space. But when you segment by different cohort, the situation is different. That complex cohort, defined by high acuity, is disproportionately growing, very strong above population. Preventative care, the flip side of that, care rendered on healthy folks, it's flat, not because of lack of need, but because a growing cohort of unengaged patients, particularly young men. Think about vaccine hesitancy in this country and how that's expanding. There is significant growth, but it's disproportionate.
You already talked about a couple pieces here. Maybe go into a little more depth. Our primary audience is mostly folks who are working on strategic planning teams. If you were leading a strategic planning team, how would you use this framework to change the way you're thinking about planning across your market today, to blend into traditional strategic planning, whether it's big annual work or ongoing service line and individual strategy assessment? How would you blend this into the work strategies you're already doing?
If I look back at my time on the provider side, I wish I would have had a comprehensive tool like this as a conversation starter. I worked in oncology and women and children, so we were always trying to quantify what services were offered. And that's a lot of service when you tally up across many locations, whether it's primary care that's feeding into oncology, your specialty office locations, it's imaging centers, freestanding surgery centers, all of that. It's a lot to wrap your arms around. It always felt like a daunting task to start, let alone finish. The simplicity of this tool and that it breaks down the outpatient space into manageable chunks. If I wanted to, in a past life, focus on one location and the care provided there, I could do that in a meaningful way. Or if I wanted to look at my service line as a whole, I could see where the growth was going to lie and match that with the resources that we had to impactfully map locations and care cohorts and pull it all together into a conversation instead of trying to conceptualize it in our heads during meetings and carry out a plan from there.
Rachel, you're dead on target there. Remembering that strategy is all about decisions. What are the questions is a way for us to map out the market, the system, and potentially margin opportunity by outpatient portfolio cohort. Break into each of those. And what I would do if I was leading a team at a large health system, first, I'd map the market and ask, where do you disrupt, differentiate, or deselect? Transactional is where we've seen a significant amount of deselections in the past year. In April, there were, within a couple of weeks, the so-called disruptors, Walmart Health, Walgreens, Village MD, United Healthcare's Optum Virtual Care, all announced major closures. It was due to a lack of patient engagement, reimbursement challenges of already low cost, low margin services, and duplicative rather than replacement of virtual care services that contributed to a collective re-examination of these business models. Our clients may have a different evaluation, but these other entities could have benefited from an outpatient portfolio breakout. Second, we've seen disruption in the transactional bin as well, particularly in the anti-obesity medicine space, a lot of direct-to-consumer activity. And this is very transactional due to cash pay nature of these business models, but continuing to disrupt or potentially replicate some of those models for our clients. Finally, differentiation is essential for AMCs to think about those complex and tertiary patients, particularly cancer patients, retaining those patients within as opposed to having them go to community systems. More NCI centers and remote clinical trials are eroding the edge for AMCs, but doubling down can be very important in order to retain that market share. As we've gotten a lot larger through mergers and acquisitions, all health systems should really reconsider their outpatient space. Does mapping it out align with your ambulatory ambitions? Does what you're doing today map what you want to do tomorrow? Do you have the right expertise, or do you need to recruit or potentially retain that workforce? Here, AMCs have an edge as they generate our workforce. Also, the community has become much more aggressive at recruiting those experts away from academics. Advanced practitioners are often a blind spot to support niche subspecialists in that tertiary and complex cohort. Upskilling and allowing those folks to work at the top of their license has been very successful to scale recurring care. Pharmacists are also becoming billable clinicians in many states, and collaborative practice agreements can scale their abilities in that recurring high volume chronic care cohort. Also, high growth areas like interventional endoscopy are particularly hot, thinking about what are the upstream diseases that lead to those volumes in the procedural space. More than anything, thinking in building the right team is essential to building a loyal, happy, and healthy community, both patients and workforce in the ambulatory side. You look at that entire outpatient portfolio by segment, look where your revenue is coming, and consider the procedural pull-through by segment, but also the many ancillary services associated with each cohort. For instance, infusions map primarily to the recurring cohort, and hospitals are making significant margins in this space. Have you established a comprehensive program that retains those pharmacy referrals within your system? Do you have the right sites in your system of care to capture? There are unconventional service lines that you can use to establish ancillary revenue in addition to that procedural pull-through. You're thinking about vertical integration as a potential opportunity, given those market gaps left by the April deselection. Health systems potentially can capitalize on where those retail disruptors failed to show anyone the money, creating new wraparound services. It's not just the E&M visit, it's all that the health system provides and the value within that they can be beneficial.
Rachael and Justin, thanks so much for the really concise and thorough explanation of what the tool is and how we've been working with our members to use it and how they can continue using it. Thanks for sharing your perspective. Look forward to hearing you again on Sg2 Perspective. Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at Sg2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, Sg2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You can find them at Vizient /podcasts. Have a great day.